All right, so my name is Waleed Brinjikji. I'm one of the neurointerventional fellows here at Toronto Western. And I'm going to be talking about conscious sedation versus general anesthesia in stroke. These are disclosures. So, the debate between general anesthesia and conscious sedation, it's a heated debate, and I want to kind of take you through, my experience and evolution on this topic over time. So we have our anti-GA zealot represented by Calvin here, and we have our GA zealot who is Susie. And for those of you who don't know, Calvin and Hobbes is a very famous cartoon in the States. So the anti-GA zealot knows that general anesthesia is bad, and they know that the anesthesiologist is killing their patients by giving them general anesthesia, whereas the GA zealot has a feeling that this anti-GA guy is just completely out of his mind and has no idea what they're talking about. Just to give you guys a frame of the scope of the problem, there's a wide variation in the use of general anesthesia when you look at registries, when you look at polls and all that kind of stuff. So like a poll of the SNIS membership in 2016 found that less than 20% of people were routinely using general anesthesia during a stroke intervention, whereas a registry, the endostroke registry, which is based out of Germany, found that over 90% of centers were using general anesthesia during stroke intervention. So there's a wide variation, particularly geographic variation. I did a very scientific poll on Twitter and found that about 60% of people were saying that they're using conscious sedation, about a third are using general anesthesia. Looking at the clinical trials, we find that, in general, GA was falling out of favor in these clinical trials, but still there was some wide variation. In Revascat and Escape, we had less than 10% of patients getting general anesthesia during the trials, whereas in Mr. Clean and Swift Prime, it was about 35 to 40% of patients. So still wide variation. Now, the GA zealot knows that GA is falling out of favor. Reasons why: it's too slow, it causes hypotension, drugs are bad for the brain generally, and we're killing our patients with GA. But the GA zealot would counter that GA leads to shorter procedures, better TICI, lower complications, and really no difference in clinical outcomes. So we can explore that topic with some data. Right now, there's just been dozens of studies on this topic, and whenever there's dozens of studies in a topic, it's hard to distill things down. But there are a few things that we know, right? One of them is that hypotension is bad. You don't want your patient to be hypotensive during your stroke intervention procedure. And in the setting of GA, this study by Loheg and Hendon, they found that patients who had a drop of MAP of 40% of baseline or higher had a significantly lower rates of good neurological outcome or good functional outcome at 90 days. And the same thing has been shown that even in conscious sedation, in the setting of conscious sedation, basically, no matter what the NIHSS, if your MAP goes low, if it falls even below 70, your expected rate of good functional outcome is lower. We also know that in general anesthesia causes more hypotension, and this has been demonstrated in several studies, and particularly during the induction phase of the anesthetic. That's where we start to see the patients drop down in the 90s, low 100s, and that can be dangerous to the patient. And these are just two such examples of such studies. Now, I'm sure many of you are familiar with the story of Robin Hood. Robin Hood, he stole from the rich and he gave to the poor, right? And there's this phenomenon that's discussed over and over in the literature called the reverse Robin Hood syndrome in acute ischemic stroke. And the idea is that when you have your ischemic territory, you're basically maximally dilated in the penumbral tissue, right? And in this, people propose that if you give a patient something like propofol or a volatile anesthetic agent, you're going to get vasodilatation in the normal brain, and you basically get shunting of blood away from the ischemic brain to the normal brain. So you're stealing blood flow from the poor brain and giving to the rich. So it's the reverse of Robin Hood. It's called capitalism. And This is the thing. This article is one of the most cited articles in the stroke intervention literature regarding the risk of anesthesia during stroke. And the problem is that there's two problems, right? Number one, the article had nothing to do with anesthesia during stroke, so that's a big problem. And then the other problem was that if you talk to an anesthetist, they would say that, yeah, at really high doses in dogs or mice, if you give them halothane or sevoflurane, you will get this reverse, this reverse Robin Hood syndrome. But at the doses that we give humans in a clinical setting, you just don't see it. So that's called fake news now. Now, one of the things that I enjoy doing, it's a hobby. If there's a lot of papers about something, I like to do a meta-analysis. So we looked at outcomes of GA versus conscious sedation, and there's a few things I just wanted to go over, right? So the one argument about procedure time, does GA result in faster procedure times? And the answer to that is yes. In general, GA does result in faster procedure times. However, we do lose time in terms of the time to groin, because if you get a MAC, a conscious sedation, your time to groin is significantly less than patients who get GA. So in the end, I think things probably balance out. Now, what about complications? Respiratory complication rates, aspiration pneumonias, failure to extubate, et cetera, are significantly higher in the GA population than in the conscious sedation population. And interestingly, I was expecting to find that conscious sedation would result in higher risk of vascular complications, but that was not the case. There was actually a trend towards higher rates of vascular complications in GA, and I can't exactly explain why that's the case. Revascularization rates, absolutely no difference in outcomes. And now the most important things are mortality and functional outcome, right? So patients who get a GA actually have significantly 2 times higher odds of mortality than those getting conscious sedation. And the rate of good neurological outcome is significantly higher in patients getting conscious sedation than GA. So where it counts, it seems that conscious sedation is the winner. So I emerged from this saying, yeah, GA is bad, bad, bad. And I go around and I tell the anesthetist, hey, stop giving my patients GA. And they always like to say, well, the devils are in the details. I'm an anesthesiologist, you're a radiologist. Let's look into some nuance, right? So bias in these, quote, comparative studies, right? So this is courtesy of an anesthesiologist. Actually, he took all the studies in this meta-analysis that we worked on and said, everything you're saying is BS. So first of all, about half of the studies show that you have a higher NIHSS, that basically at baseline, NIHSS was higher in the GA group. So that means right there, they're not really comparable. In about a third of the studies, there were more vertebrobasilar strokes in the GA group than the conscious sedation group. Only about a third of the studies published on this topic are from the modern era. About a fifth are not contemporaneous. In other words, the anesthesia patients were done at an earlier time point than the conscious sedation patients. You're essentially comparing Mercy to stent retriever. And just so you guys know, I'm young enough that I've actually never seen a Mercy. I don't even know what it looks like. In about 70% of cases, it's not really sure why intubation was performed, and the anesthesiologist made sure to point this out to me, that in about over a third of the cases, there was no anesthesiologist as the co-author. And I'm just going to say that I think it is reasonable for anesthesiologists to be included in co-authorship in anesthesia-related studies. All right. So now just talking about the Siesta trial, this is a nice painting, from Van Gogh. This is the first trial that came out on, conscious sedation versus general anesthesia in stroke. And they found their primary outcome was NIHSS at 24 hours, and they found no difference between groups. And essentially, no matter how they cut the data, they could find no subgroup where there was a difference at that 24-hour outcome. What was interesting, though, was that at 90 days, if you looked at MRS at 90 days, there was actually a significantly higher proportion of patients in the GA group having good functional outcome at 90 days than the conscious sedation group. So completely opposite what many of us had expected. Now, these are the results of the Goliath study that have not been published yet, but they were presented at the European Stroke Conference. And they found that patients that got a GA had significantly higher rates of good neurological outcome than those who got conscious sedation. These are randomized, controlled trials, single center. And then we have stroke, which was published in Stroke, and they found no difference in neurological outcome at 90 days. So if you look at the summary of these RCTs, if you just meta-analyze them, compile their data, what you find is that the rate of good neurological outcome is significantly higher in the GA group than the conscious sedation group. So completely contradicting everything that came up in the prior literature. So the GA zealot knows, we made anesthesia great again, and they bought a nice hat. Okay? And now the anti-GA zealot wants the details. Now he wants to know the details, right? So now we got to go look at the details. So there's just a couple interesting findings, right? So first of all, if you look at the data, and I don't have the data from the Goliath study yet, but siesta and stroke, the rate of conversion from conscious sedation to GA was, I would say, astronomically high, about maybe. Because if you look at the general literature, it's about 2 to 3%, and here we're looking at 14 to 16% of patients. And just from anecdotal experience, I've only seen 1 or 2 patients get converted in the middle of a procedure. And the problem with that is when you're doing an intention to treat analysis, if you're having 15 to 20% of your patients, 14 to 16% of your patients getting converted, that's going to change your result. That could significantly impact your results. And those patients are, they're going to have a worse outcome because they just got an emergency intubation, which is associated with a lot of complications. Now I'm going to pick on siesta. So here are the Hermes data, right? This is the Hermes conscious sedation, Hermes GA, Hermes TPA, and now here's siesta conscious sedation. And the one thing that really stood out to me was that the conscious sedation group in siesta actually did worse than the TPA group in Hermes. So that's something that makes me wonder exactly what went on. Why is it that these conscious sedation patients did so poorly? And if you talk to some of the investigators from that trial, they would say that stroke was not routinely performed with conscious sedation prior to that trial. And then all of a sudden, I guess if you're taking somebody who's used to working in a nice controlled GA environment and then putting them in, basically thrombectomy / wrestling with the patient / being a counselor mode, it could, impact their ability to perform the operation effectively. But that's just a guess, right? Now this is where all the uncertainty lies, right? So if you look at Hermes, 50% of patients that got a MAC, that got conscious sedation, had an MRS of 0 to 2 at 3 months. And of the GA, 36% had good outcomes, okay? Whereas in the RCTs, you have 50% of the patients that got GA had good outcome at 3 months, compared to 36% of patients that got a MAC. So the results from the literature, I would say the 2 best compilations of literature to date are completely contradictory. And it's basically, I would say, interpreting these data, it's like looking at one of these Rorschach tests. You see what you want to see, and what you see is a reflection of your experiences and your biases. So I look at these trials and I say, well, they didn't do this right, and this, and this, and this. But then somebody else would look at Hermes and say, well, this is obviously biased, because only the worst patients are getting a GA. So, it really influences how we interpret the data. So in conclusion, is the debate solved? I would say it's not solved. And, at the conclusion of this, at the beginning I thought I knew everything, but now I know nothing. And I'm over the details. So thank you.